In this talk, I review two different topics. The first one is how to identify patients at risk of melanoma, and later how to manage them. To identify patients at risk of melanoma, it's extremely important to identify this genetic susceptibility. And for this reason, we need to know if the patient has family history of melanoma, a previous history of melanoma, if the patient already had multiple primary melanoma, because these patients have 25% of possibilities to develop another melanoma in the next 10 years. Patients with other skin cancers different to melanoma are also an increased risk to melanoma. And finally, the personal or familial history of other cancers that can be also associated to the risk of melanoma. Second, risk factors for melanoma are associated to the phenotype, and between them, the most important one is the number of nevi. Patients with a high number of nevi have between 5, 10, 15 times more risk to develop melanoma. Then patients with fair skin, fair hair color, or fair color of the eyes, blue eyes, green eyes, they have 1.5, 2 times more risk to develop melanoma. And finally, environmental factors. It means previous histories of sunburns, sunny holidays, chronic sun exposure, or immune suppression. All of them also increase the risk to develop melanoma. As soon as we identify a patient at risk to develop melanoma, what we recommend is sun avoidance, sun protection, and dermatological follow-up. This dermatological follow-up can include total body skin examination and dermoscopy of all the lesions, and in patients with many moles or personal familial history of melanoma or multiple primary melanomas, total body imaging that we can use 2D images or 3D images with a 3D reconstruction and digital dermoscopy. We should perform this examination twice a year in high-risk patients. And we can offer also to these high-risk patients with personal history of multiple primary melanoma or familial history of melanoma, genetic counseling and genetic testing. In the case that we identify mutations in a high-risk susceptibility genes, then we can identify the risk to other tumors, and we can perform and offer the screening for the other tumors. And only as an example, carriers of a mutation in MITF, they need a specific follow-up for skin cancer and melanoma, but also to renal cancer with ultrasonography of the kidney every year. Or another example, patients with mutations in CDKN2A have an increased risk of breast cancer, lung cancer, and pancreatic cancer. And we also have specific programs for early detection of these other tumors in addition to the melanoma.